All right, so it is 12 o'clock. Welcome, everybody. We can go ahead and get started. I'm sure more people will trickle in as we move through the meeting. I just want to make sure that our presenter has enough time to get through a topic that needs a lot of time. It's complex for primary care. All right, so I'm Gabby Gibson Lopez. I am one of the co-chairs for the PCBH SIG. Just some housekeeping stuff. We'll be just going over some brief announcements, and then I'll be introducing our speaker, and then we'll have some closing remarks. So again, if you're new to the SIG, welcome. And if you want to be officially subscribed to the SIG, you can send an email to our secretary, Stacy, who can help you join the SIG, or you can just go to the website and scroll to the bottom. There's an option where you can click join SIG. Remember, if you are interested in looking for new jobs, you can always go to CFHA to look at the job posts. Anybody here have any job announcements that they want to make? Anybody hiring? Just a quick announcement or a shout out. Nope.
Santa Rosa Community Health just got a grant to implement a PCBH model in our peds clinic, so we will be looking for people soon.
Awesome. Thank you, Tara. All right. And as always, if you want to send a message out to the PCBH SIG members, you can do so using the Listserv, the CFHA Listserv email, and that's cfha@gaggle.email. And then, of course, keep an eye out for our newsletter. It just went out. It usually goes out on a quarterly basis and a few days before our webinars. Again, this is just some faces for our leadership team and our PCBH SIG this year. Some of these folks will be staying on for next year as well. This is our meeting schedule. So we've already done our first meeting that took place on the 7th of February. Today we will be doing our second meeting, and we will be covering the topic of neurocognitive disorders. And then the following meetings, we will be covering chronic pain. This will be a panel of speakers that will take place June 5th. We will cover the topic of obesity management in primary care August 7th. Our October meeting will take place in person at the conference in San Antonio, Texas, and then December 4th we will be covering perinatal mental health, and that'll also be a panel of speakers. So pencil is in your calendars for those dates. Just a reminder that the servant Latinx populations in primary care behavioral health group is housed under the PCBH SIG, and they are actually under new leadership. They will be coming on board, and they will be planning some programming for the rest of the year. It seems like they have some pretty good topics that they will be scheduling some webinars and presentations on. So we will collaborate with them and make those announcements throughout the year. And it's just as a reminder, we do have the mentorship connector. So if you are interested in being a mentor, or if you are wanting mentorship, you can always go to our website and fill out some forms. And this is just to gather some information so that we can be able to match you or pair you up with a mentor. We have a good list of mentors that are leaders in the PCBH community who are wanting to mentor, and we are needing some mentees. So if you're interested, please fill out this form. You can scan this QR code and that will take you to that. And then we have a survey. We always want to get your feedback about what would be helpful in terms of webinars or just programming for the year. So if you want to give us some feedback, we have a survey that you can access here or on our website to give us feedback in terms of topics, presenters for the year. All right, and lastly, but Definitely not least, our presenter, Dr. Laura Schultz. She is our PCBH SIG co-chair. She will be talking today about identifying and treating neurocognitive disorders in primary care. Just a little bit of background of Dr. Schultz. She is a licensed clinical psychologist who is passionate about integrating behavioral health into medical settings. She currently serves as a senior director of behavioral health for ambulatory care at Methodist
Le Bonheur.
There we go.
It's not as fancy.
Healthcare in Memphis, Tennessee. At Methodist, Laura leads a team of embedded behavioral health providers within the outpatient medical practices who collaborate with the medical providers to provide more holistic care for the patients they serve. This is the second integrated behavioral health program that Dr. Schultz has developed. Prior to Methodist, she led the integration behavioral health services in a large federally qualified health center, also in Memphis. Her clinical areas of specialty include health psychology, neuropsychology, and the integration of religious faith and psychology and trauma. She earned a master's in counseling at Covenant Theological Seminary and then completed her doctorate in psychology at Wheaton College. She completed her clinical internship with a specialty in neuropsychology at the North Texas VA healthcare system and then went on to complete an APPCN specialty postdoctoral fellowship in clinical neuropsychology at the Memphis VA Medical Center. She is a board certified by the American Board of Professional Psychology and Clinical Health Psychology. When she is not geeking out over psychology, Dr. Schultz delights in being a wife and mother to her 3 young boys. So welcome, Dr. Schultz, and I'll stop sharing so you can share your screen.
Thanks, Gabby. I appreciate it. Let me get mine shared too. All right. How's that? Do y'all have the slides? Okay, thanks. Thanks for having me. This is a big topic, way more than I can cover in 45 minutes. So I might have to move through some things pretty fast, but here's what we're going to talk about today. And I love talking about neurocognitive disorders in primary care because I do think it is so important. So we're going to start by just talking about why is this important? And then I want to give you a big picture framework of what types of things cause neurocognitive disorders, because not all things are Alzheimer's disease. And while that is the most prevalent, we really need to have our thinking hats on when patients come in with a variety of cognitive concerns so we can help guide our team. So we're going to talk a little bit about differential diagnosis. How do we decide if it's normal aging or more than that? And what area should we look at to make those decisions? What tools should we use in our assessment? And then once we've identified some sort of a neurocognitive concern, what can we as behavioral health consultants in primary care do to help? So that's where we're going in 40 minutes, I'm hoping, or less. So big picture, y'all, everybody's getting older. You've probably heard these statistics, but in the US, there's 10,000 baby boomers that turn 65 every single day. If you look at some of the statistics, older Americans have increased by 36% since 2009, while the under 65 population has increased by only 3% during that time. So this is one of the most rapidly growing groups of individuals that we serve. And so very important that we're familiar with some of the concerns that they have. Also, neurocognitive disorders are commonly missed as diagnoses in primary care. Over half of people with dementia, living with dementia, some with mild and even moderate stage, have never been diagnosed by a physician. And this gets even worse when we start looking at different cultural groups. So for example, some new research came out looking at Black individuals that have dementia of the Alzheimer's type. They were 35% less likely to be diagnosed with Alzheimer's or related dementias versus their white colleagues or peers, despite the fact that we know that Black Americans are twice as likely to develop dementia than whites. So we know there's this discrepancy, but we're missing it even more commonly in our Black patients. And this unknown diagnosis leads to unnecessary suffering and burden for our patients. So why do we need to work on detecting neurocognitive disorders? Really, this is an opportunity for our patients to get better care. if they can benefit from, if they can get the medication that they need, if there is treatment available, they are more likely to benefit if they get that early. It also lets our patients have more time to participate. If we can catch it early enough and we know there's a concern, especially if it's a potentially progressive condition, they might be able to participate in some of their future planning. So naming people that they want to serve as, power of attorneys, naming what they want that to look like when their memory progresses.
Uh-oh. I think she froze. Laura?
Hello? Hello,
You froze.
hello?
Yeah, you froze for a bit.
I'm sorry. Am I back?
Yes.
Okay. Um, so letting our patients participate in their planning. Also, when we know there's neurocognitive concerns, this is really helpful in addressing other comorbid medical conditions. So these are your patients, potentially one of the reasons why a patient might have a challenge, complying with their medication for their diabetes regimen or their blood pressure. If they're forgetting to take their medication and we don't know that there is a neurocognitive disorder contributing, caregivers who need to be in good care for themselves as well so they can care for their loved one. So, big picture, what is a neurocognitive disorder? The term major neurocognitive disorder replaced the term dementia in the DSM-5. So, if you think about the DSM-4 and before, what was required for a diagnosis of dementia was a significant deficit in memory plus another neurocognitive domain, and it had to lead to a significant decline in functioning. The DSM-5, they got a little bit more flexible with that and said now there needs to be substantial decline from previous functioning, in addition to decline in one or more cognitive domains. But they took memory out as a specific requirement. And that you'll see as we go into the different etiologies of dementia is really important, because sometimes memory is not the first thing that gets impacted by a neurocognitive disorder. Also, another thing to keep in mind is a phrase mild neurocognitive disorder. This used to be called MCI, mild cognitive impairment. It's the same thing, kind of renamed. But this is a step down from major neurocognitive disorder. We're saying that we acknowledge that there is at least one cognitive domain that has significantly declined from baseline, but the functioning of the individual has not been yet impacted significantly. So when you think about, does a patient have a neurocognitive disorder, one of your first decisions is it a major neurocognitive disorder or mild? And their impact on their functioning is frequently one of the best ways that you can make a decision on if it's mild or major. All right, so how often does this come up? Well, in developed countries, prevalence of dementia is around 1.5% at 65, but it keeps doubling every 4 years after 65. So by the time our patients are in their 80s, approximately 30% of them would meet the criteria for dementia or major neurocognitive others. So you can have those in the back of your mind as you're working with your patients. All right, jumping in. Alzheimer's disease is our most common type of dementia. And if you take a look at this picture here, you can see what Alzheimer's does to the actual brain. This is a healthy brain on the left. Look at that plump cerebral cortex. The hippocampus is nice and full. And then if we flip over to the other side, you're going to notice, look at the atrophy that has happened to the cortex, the shrinkage of the hippocampus, the enlarged ventricles, which is really more secondary to the shrinkage of the cortex. That's what your brain looks like after Alzheimer's disease. So there's some very significant changes that happen. And one of the things that I think is helpful as you're sitting with patients is just to understand really how Alzheimer's disease typically presents. Patients typically have what we would call an insidious onset. What does that mean? That means when we ask the question, when did this begin? They say, oh, I don't know, maybe a few years ago. It's probably gotten a little bit worse over time. I can't really name exactly when it started, but I started noticing it maybe, you know, a year and a half ago. So there's not a clear demarcation. It started February 5th, 2022. They know it happened a while ago, and they're reporting kind of the slow, gradual decline. Typically with Alzheimer's type dementia, complaints do start with memory, and then they would progress to including other cognitive domains. So for example, a patient might start by having problems remembering recent conversations, names, events. Loved ones frequently say they're repeating themselves a lot. They've asked me the same question. We just had a phone conversation, but you know, then I talked to her 4 hours later and she doesn't remember that I called. Also, you can start to see at the beginning more apathy, some depression, and then as the disease progresses, language is frequently hit. One of the hallmarks for language impairment with Alzheimer's disease, we see a lot of word finding difficulties. So patients are talking around the words they want to use, but can't exactly call the name of the word. I unfortunately lost my grandmother to Alzheimer's disease, and I remember sitting on her bedside with her, and she was pointing to the shoe, and she wanted me to hand her shoe, but she couldn't get there. So she said, "Can you hand me the thing on my foot, toes, walking?" So she knew what the shoe was used for, but she just couldn't see behavior changes. And it can get even to the point where it progresses to physical impairment, difficulty with speaking, swallowing, walking, etc. In terms of treatment for Alzheimer's disease, cholinesterase inhibitors and memantine are the two primary types of medications. These seem to delay worsening of symptoms for about 6 to 12 months on average for about half the people who are taking them. So this is not a magic bullet. We don't have a cure. The way I explain it to patients, because I think once they get the diagnosis, they want to know, okay, what do I do about this? And unfortunately, we don't have the best treatments yet. So the way I explain it to patients is we're going to start you on this medication, and our hope is that it's going to slow the progression of this condition. So if we think about a truck parked on a mountain, that truck is eventually going to roll downhill. But if we throw the emergency brake on, it's going to roll down a little bit more slowly. So the medication functions kind of like an emergency brake with a progressive dementia like Alzheimer's disease, where we're hoping it's going to slow down the decline, but it's not going to altogether stop the decline. And I think setting those realistic expectations for our patients can be really helpful, and for their family members as well. The other thing that I want to bring up about Alzheimer's disease is that if patients are diagnosed with mild cognitive impairment or mild neurocognitive disorder, as we discussed before, especially if memory is their primary concern, about 15% of those patients will progress to where it becomes a major neurocognitive disorder secondary to Alzheimer's disease within a year, and 40% will progress within 4 years. So if you're doing your assessment and they're reporting these memory concerns and you're documenting memory concerns, but they say it's not impacting their functioning yet, we need to monitor those people pretty closely, because it's likely that they're going to fall into this category as time progresses. Next up, vascular cognitive impairment. This has previously been known as vascular dementia, post-stroke dementia, multi-infarct dementia. As its name implies, this is dementia that is caused due to cerebrovascular disease that can include small or large vessel involvement. If you take a look at this image of the brain here, you've got this giant infarct right here. That was a stroke. And this hole in the brain is what's left from that. And then you can see kind of this gray down here. These are more white matter hyperintensities that reflect small vessel disease. So not necessarily a major infarct, but definitely some burden on the brain due to cerebrovascular insufficiencies. And this course is very different than Alzheimer's. Remember, we talked about that insidious onset where they don't know when it started. Usually a person with a vascular cognitive impairment can tell you it was on February 5th when grandma had the stroke. And it proceeds very differently. Instead of just a gradual progression, this isn't really a progressive disease unless they have additional cerebrovascular burden. So you're going to see what we call a stepwise progression. So they have a stroke and they do, they come down, And then they kind of hang a little bit longer unless they have another stroke. And then their functioning comes down a little bit more. And then they hang a little longer and then they have another stroke. So that's what we describe as that stepwise progression. It looks different than Alzheimer's disease. However, it is commonly coexisting with Alzheimer's type dementia for a lot of folks. So you can have neurocognitive disorder with both overlaid. You have a patient with Alzheimer's disease who then has a stroke. They're going to have a more precipitous decline in their functioning. The way this presents is very different than Alzheimer's disease as well. Depending on where the stroke is in the brain, the extent of the damage, you can see a lot of different areas of cognitive functioning impacted. Typically with vascular dementia, processing speed, complex attention, executive functioning is most likely to be hit. People just think much more slowly. But depending on where the stroke was, everybody knows probably a patient who had a massive stroke and lost the ability to speak. That's because where the stroke was kind of the primary language area of the brain. So it's quite variable in presentation. And that means it requires a really individualized approach to treatment and intervention as well. In patients with agitation, with vascular dementia, we really want to consider environmental modification, and sometimes pharmacological interventions can be helpful as well, but there's not really a medication to bring back the memory or slow the progression in this disease like there is with Alzheimer's disease. All right, third on our list of most common etiologies is Lewy body disease. And I have a picture of Robin Williams here because he's unfortunately one of the individuals who suffered from this condition and was in the news a little bit more recently. He was initially diagnosed in 2014 with Parkinson's disease, but then died by suicide 3 months later. And on autopsy, it was actually learned that he was misdiagnosed and that he actually suffered from Lewy body dementia. The difference is really these Lewy bodies right here. They're responsible for both Parkinson's disease and Lewy body dementia. It's just where they set up in the brain. So if they set up in the substantia nigra, the subcortex, that's how we end up with Parkinson's disease. If they set up in the cortex in general, that's how we end up with Lewy body dementia. And these folks present very differently. Often visual hallucinations are one of the first things that you're going to hear from your patients pretty early in the disease process, and those are present for about 80% of patients with this condition. Why is this important? I think about us in primary care. How many times do we get handoffs for a patient who's seeing things? And if it's an older adult, who has not had a prior psychiatric history, we should be thinking, could there be a neurological component to this? Hallucinations for Lewy body dementia stereotypically are fully formed. They're visual hallucinations that are fully formed. One of the things that we talk about is something called Lilliputian hallucinations. They frequently involve seeing little people or little animals that are fully formed. So I have patients who would say, there were these little children that were at my dining room table and they're having great conversations with them, but their partner is not seeing them. When you start to hear little people, little animals, and it's someone who's having hallucinations later in life that hasn't before, this should pop on your radar. Also, these patients have pretty significant fluctuations in their cognition, frequently have problems with their balance. REM, sleep behavior disorder, is very common in these patients as well as some Parkinsonian symptoms. When we compare these patients to Alzheimer's patients, patients with dementia with Lewy body are going to do better on naming measures and even some memory measures like verbal memory, and they're going to do worse on things like advanced problem solving and visual spatial abilities. So the test profile, if you were to send them to a neuropsychologist, looks very different between these patients and Alzheimer's disease patients as well. And this disease, unfortunately, does seem to be faster in progression. It's about a 7-year lifespan from diagnosis on average versus 9 in Alzheimer's disease. And the neuropsychological impairment seems to be much faster for these patients as well. All right, we're going to move quickly so I can just give you high level on some of these other dementias. Although frontal temporal dementia, I would put it number 4 in terms of most common. And I have a picture of Bruce Willis down here, who is currently suffering from a variant of frontal temporal dementia. So there's 2 big types of FTD, and I want you to take a look at this picture on the left of the brain. We've got a normal brain on the left, and then a patient with frontal temporal dementia on the right. And you can actually see the atrophy in the frontal lobes there, a hallmark of frontal temporal dementia. But there's 2 primary variants. The behavioral variant, these patients typically experience prominent. His wife came in, and the patient had actually been a pastor and was a pastor, and was very conservative in general. And all of a sudden, over time, the wife started noticing that he was slapping waitresses on the rear as they would walk by. He was saying crude things out loud. Signs. And then there's the secondary one that is also pretty common, and that is primary progressive aphasia. So these individuals typically present with language impairment first: language, speaking, writing, comprehension. This also normally hits before 65, but it could occur later. Unfortunately, this condition, FTD, is a more rapid progression as well. I think I read an article recently that Bruce Willis can no longer communicate at all verbally. And about 60% of patients with FTD are between 45 and 64. So it is going to hit earlier. In terms of treatment, there's really limited evidence for efficacy of pharmacological treatments. There's some evidence for using SSRIs and trazodone for the behavioral symptoms, limited evidence for use of our cholinesterase inhibitors. Some people say it helps, some people say it makes it worse. Instead, we're really encouraged to focus on helping with compensatory strategies and helping patients use value-based meaning making in their life, and supporting caregivers as well. All right, Parkinson's related neurocognitive disorder. Another one of our stars struggling with this condition. Michael J. Fox was diagnosed really young with Parkinson's disease at just 29 years old. As we discussed before, Parkinson's disease occurs when the Lewy body is set up within the substantia nigra. And Parkinson's disease usually hits after 60, but about 5 to 10% do have that earlier onset. Not all patients with Parkinson's disease go on to develop neurocognitive concerns. In fact, that hits only about 20 to 50% of Parkinson's patients. Others typically just have the motor concerns. But we do see very different profiles in Parkinson's related dementia than we would in the other ones. In fact, kind of hallmarks: attention problems, problems in executive functioning, visual spatial, and then the memory problems are very distinct. So with Alzheimer's dementia, it tends to be what we call an encoding deficit. The information that we're learning just doesn't stick when it goes in. But with subcortical profiles of dementia, which is much more common in Parkinson's disease, the information goes in, but it's really hard to retrieve and get out. So I explain it to my patients when I'm trying to explain it, and I say, pretend for Alzheimer's they have a bucket. It has a bottom. It's just really deep. So the information goes in, but then getting it out is very difficult. So these patients benefit from cueing when they need to have like a memory, when they have a memory task. The information's in, it's just harder for them to get out. One thing to note, Parkinson's related dementia can be really difficult to tease apart from dementia with Lewy body disease. So one little rule of thumb to help you think about it is, if the cognitive or behavioral deficits emerge before or within 1 year of the movement concerns, then it's probably dementia with Lewy bodies. Whereas if the patient has a movement disorder for a year or more before they start to experience cognitive deficits, primary care practitioners should be aware of. You can see here that there's just too much cerebral spinal fluid in this person's brain. The classic things that you will see, the memory mnemonic I use, wet, wacky, and wobbly. So a patient may present with cognitive concerns, urinary incontinence, and change in their gait. This is a relatively rare condition, but I've caught it in primary care before, where I noticed the symptoms and went to the PCP and said, hey, can we get some neuroimaging on this guy? I'm a little concerned he could have NPH. Sure enough, he did. And why this is really helpful to catch fast is because there is some treatment. Shunting, serial lumbar punctures, both of those can be really helpful in actually restoring some functioning for these individuals. So known as chronic traumatic encephalopathy. We think about that with our boxers, our football players. But typically, if a patient experiences just one trauma due to a motor vehicle accident or combat, we would expect that over time, their cognitive functioning would improve depending on the level of severity of the injury. Again, I don't have time to go over all of this in detail, but we should be thinking about neurocognitive concerns in our patients with substance abuse issues. There are some data that suggest that possibly 10% of all dementias are secondary to substance use concerns. And we really want to be aware of any time someone is abusing alcohol and also getting poor nutrition. That combination of alcohol and a thiamine deficiency can lead to a non-reversible dementia called Wernicke-Korsakoff syndrome that can be really impairing for our patients. So when you see these patients struggling with alcohol, talking with your PCP about if thiamine supplementation could be helpful if they're not willing to reduce their alcohol use. Another population we want to be aware of where we can see some neurocognitive concerns is our patients that we treat with HIV and AIDS. As HIV is not managed well, when it is not managed and treated well. All right, so how do we decide if we're looking at a potential neurocognitive disorder or if it's something else? I think it's really important for us to keep in mind that all of our brains do kind of slow down a little bit after we age. Our processing speed peaks at like 18 or 19. Short-term memory, we do really well and we go up until about 25 and we kind of level up. And then after 35, it's downhill for most of us. The only thing that's really an exception is vocabulary seems to peak when we're in our 60s or 70s, which is great. But the main thing to keep in mind here, it's really important for our patients who are older, who come in and think, oh my gosh, I have Alzheimer's disease. I don't think as fast as I did when I was 30. That's really normal. None of us think as fast as we did when we were 30. But here's some tips in terms of, is this typical age-related changes or do we need to look at something more? An occasional missing of a bill is really different than somebody who can't manage their checkbook and doesn't know how to manage their finances at all. Sometimes forgetting what word to use. I'm sure I will during this presentation at some point. We all notice it when we don't get good sleep, but that's very different than having that become a repeated issue and having difficulty having a conversation. Losing your keys because you were really stressed at work and your kids were crying for you when you came in is very different than misplacing objects repeatedly and not being able to retrace your steps on a regular basis in order to find them. So when a patient presents, have them give you some examples. I hear you're having some concerns with your memory. Tell me about what that looks like for you and how frequently is that happening, to help you kind of tease apart, is this something that is more significant or not? One thing I forgot to mention with Alzheimer's disease, specifically, since that's our most common type of dementia, is anosognosia is really common, which means that your patients frequently don't know they have a memory problem. Typically, it's the loved ones who's bringing them in saying they have concerns. So as a general rule, if an older adult sits in my chair and says, I think I might have Alzheimer's disease, my first thought is you probably don't, just because they have that awareness. And so it's likely that they are a worried, well, typical ager, or there's something else that might be going on that we can identify. All right, delirium, another thing for us all to be aware of. Really, I want folks to think about this when cognitive concerns come on very rapidly and fluctuate in severity, and you have prominent deficits in attention and awareness. And this can be the result of so many medical concerns. You know, we think about our older adults that have urinary tract infections. That can put them at risk for delirium. Changes in medication, surgery coming out of that, you know, that surgery room. Sometimes this resolves within hours to days, but it could take much longer. So the treatment here is to identify what is the cause of the delirium. If someone says, you know, grandma was super functioning and going to all the things just last week, and then she had a surgery and now she doesn't know her name, that's not a dementia. That's likely a delirium. So we want to rule that out when we're thinking about neurocognitive disorders as well. And then other medical etiologies, we call these the reversible dementias. So these are things that we want to consider. So often I see patients presenting with cognitive concerns and they've been recently started on a new medication. Or they can date back and say, when this medication was started, that's when my memory started struggling. One thing to familiarize yourself with, if you are not yet familiar, is something called the Beers criteria, BEERS. It's a list of medications that will tell you which medications are potentially contributors for high risk, you know, older adults, which ones are contraindicated due to a variety of issues, but the cognitive issues do show up. So I see a lot of patients who maybe were started on medication for bladder control, but that's anticholinergic and can cause memory concerns. So one of the first things I do when I get a patient with a referral for memory or other cognitive concerns is look at their medication list and go one by one through the Beers criteria to see if any of those could potentially be the source of the issue or contributing to the issue as well. We also want to look at metabolic, nutritional deficiencies. I recommend the lab panel that I have there to just kind of consider if any of those things might be contributing. And also depression. Geriatric depression a lot of times can look like dementia. These patients are aware that their memory is not as great as it used to be, but they usually present saying, I have good days and bad days. Their memory impairment is a little bit more mild. If it's a severe memory impairment, that is not going to be accounted for purely by depression. But typically, the course of illness is really well demarcated. So they say it happened when my spouse died or my dog died. It rapidly is progressive. And we want to think about this, especially if we see that within the context of a prior psych history or a recent crisis for that individual. All right, assessment concerns. So when I get a referral for cognitive issues, the first question I ask myself is this normal aging or something else? If it's the something else, what is the something else? Then I move on to what is the evidence-based treatment for this patient and what can I do for the caregiver? So those are my questions that I'm thinking about when I'm a behavioral health consultant in this capacity. I always start with a good clinical interview. Y'all do a lot of this, I'm sure, every day, but I want to get a good sense of their baseline cognitive functioning. I typically do this by inquiring quickly about education and occupation. That kind of lets me know if they're probably more below average, average, or above average at baseline. And then I want to drill down onto their symptoms. And I get very specific. I ask about the following neurocognitive domains. Talk with me about problems with your memory, and I give them some specific examples and try to elicit feedback from them in terms of if that's an area of impairment or not. Memory, attention, executive functioning, language, visual, spatial functioning, and motor concerns. So in my interview, I'm going to hit on all of those because they might present saying it's memory, but a lot of times it's actually attention. And attention is a building block for memory. So I need to understand and tease that apart. I also want to understand the course of the condition. So when did it start? How is it progressing? How frequently is this coming up for you? I want to understand their psychiatric history and neurological history, as well as their families, both psychiatric and neurological. And then I really want to understand how these problems are impacting their functioning day to day. So if they're coming in, walking and talking, I'm probably going to start by inquiring about their IADLs. If they're a little bit more quiet and the family member is doing most of the speaking, I might start by inquiring about their ADLs and then move up. But I really want to know where's the impairments. I usually ask them to tell me about a typical day. I want to understand if they're just getting out of bed and sitting on a couch all day long watching television, or if they are going about their day doing different activities. I want to understand substance abuse, and then I really do drill on health behaviors. Sleep is a big one for me because it has a very clear link to cognitive functioning, as well as nutrition, exercise, and medication adherence. All right, I did take out some slides in essence of time. There are some briefer cognitive screeners, the Minicog, the 6CIT. Those can be good at like a very surface level, but if someone's presenting with cognitive concerns, I'm probably going to step it up at least a little bit. The mini mental status exam, I'm sure you're all familiar with it. It is the most popular amongst medical providers. I think they all learn it in medical school, and it's pretty good for dementia assessment. But if a patient has one of those mild neurocognitive disorders, it is very unlikely to detect that. So the sensitivity is about 18% for mild neurocognitive disorder and only 78% to detect mild dementia of the Alzheimer's type. You can make it better if you use age and education adjusted normative data, which I'm happy to share with you. It can become the psychometrics get much better when you adjust for that. It's also a copyrighted instrument now, so it does have a cost to it. On the flip, there's the MoCA and the SLUMS. I've got a picture of the MoCA here. The MoCA is much more sensitive. You'll see it'll pick up 90% of the mild neurocognitive impairments and 100% of the dementia with Alzheimer's types. It's available in a lot of languages. It's public domain. You do have to get certified, do a training with them to get certified. But there's also a telehealth version that is available, which is really nice. I think they built that out during COVID. So how do I decide which one I'm going to use? If the patient presents with a ton of functional complaints and they aren't toileting or dressing themselves, I'm probably not going to go with the MoCA because they're going to get really frustrated. And I don't need that level of ammo to determine if there's a cognitive impairment. I can probably use the mini mental with age and education corrected norms and get my answer. However, if I did that and it was normal, I could go on and administer the MoCA. But otherwise, if they live alone, or if they are not reporting functional concerns that are very significant, I'm going to use the MoCA because I want to make sure I have the highest sensitivity to detect any mild sorts of concerns. All right, moving forward, a quick summary. If I suspect there's a neurocognitive disorder, I'm going to start by looking at labs and meds. I may refer to neurology or neuropsychology for further assessment. I'm going to work on providing the support to the caregiver and the patient and any behavioral interventions needed by the caregiver to address whatever concerns they're having with their loved one. If I think it's normal aging, I'm going to rule out and treat depression if it's there. I'm going to provide a lot of assurance and education. I'm going to go ahead and recommend some ongoing monitoring. And then strategies to help them cope with what is normal memory loss. And also to discuss strategies to prevent cognitive decline. All those good health behaviors, staying active, really important. If the patient has a mild neurocognitive disorder, a non-progressive dementia, or a residual neurocognitive deficits following an injury or a stroke, I may refer to neuropsychology if it would be useful to the patient for baseline testing to kind of help them understand the scope of their deficits and consider a referral for cognitive rehabilitation as well. What are other things that we can do as behavioral health consultants? I think in kind of three buckets. We're going to work on addressing the patient's concerns. We're going to work on prevention and slowing decline. And we're going to work on caring for the caregiver, because when the caregiver is healthy and well, it's best for the patient also. big patient concerns, they may have sense of despair and loss and grief that go along with that. So, how can I work with them within that? Prevention exercises, diabetes, managing all of their medical concerns, trying to promote cardio and cerebrovascular health is really important, medication adherence, and then meeting with that caregiver to determine what their burden is and what levels of support they need. And targeted behavioral interventions are really helpful for these patients as well. So, for example, finding out from the caregiver, where are you running into problems in caring for your spouse? Well, they just don't want to take their medication, or they just don't want to brush their teeth, or it's a battle every time I try to get them in the shower. Thinking through what sorts of problematic behaviors we can help with, whether that be environmental changes or instruction for the caregiver to help them, or what sorts of resources we need to get in the home to support them in that too. Some strategies I frequently give caregivers, using simple words and phrases when giving directions. Encouraging them to not talk too much. I've seen a lot of caregivers who want to give all the explanations to the loved one about why they need to take the shower, but they can't process all of that. So really being clear and direct, and then modeling those desired behaviors. For individuals with hearing loss, making sure they're speaking in a lower pitch, being patient, giving them time to process because they have a slower processing speed potentially to respond to the questions. Using pleasant events to remind loved ones of those to help elicit positive emotions before getting them to try to do something. And just making sure that we're not overwhelming them with different caregivers in the space. And actively involving them as much as possible in their own self-care activities to minimize any sense of threat. When they're sitting there and they're not processing everything that's happening, if things are being done to them, it's very different than slowing down and taking the time to allow them to participate in their own self-care, which gives them that sense of empowerment and dignity, and much elicits positive emotions for that patient, even if they can't fully describe them. Other things I just encourage us all to do as behavioral health providers is, don't discount someone's concerns. Even in individuals who are younger, a 50-year-old that walks in, what if they have one of those neurocognitive conditions that is more common in that lower age range? So take their concerns seriously, talk to the patients directly, test early, coordinate well. If a neuropsychologist has done a full robust battery, you don't need to do a MOCA. So ask them if they've ever had any sort of testing before. Be very clear with our language, but also sensitive. When we use those big words like dementia and Alzheimer's, they have a lot of weight. So don't use them if you're not confident. And reflect with them on how they're feeling when they're hearing these different sorts of things. Give patients tools for living with the disease. They're not dead, they're dealing with a condition, and so we really want to empower them to live a meaningful and values-based life. So work with them on how that can look for them. And recognize that they're individuals. They're going to experience, one patient with Alzheimer's disease is not the same as the next, and they're going to experience the disease very differently. I really view myself as a patient advocate in working with patients with cognitive disorders, and I encourage all of us to do that too, and to make sure that we're talking to them directly. One little thing that's so easy to do is, a lot of times when a patient presents, and an older adult especially, and there's a report of some memory concerns, a lot of times a child or a partner is with them. And I see over and over behavioral health providers looking to the partner or the family member and asking all the questions there before even giving the patient a chance to speak. We can dignify them so much, even if they can't come up with the answers, by asking them our questions first, and then asking their permission to also ask their loved one the same question. So a lot of times that's how I start my interview. Susie, I'm going to ask you some questions. And then if you don't know, or if your loved one has a little bit more that they'd like to add, I might ask them after. Is that okay? But always starting with that patient so you can have a patient-centered interaction. All right. I think that's it. For my high level overview, I'd love to take a few minutes to answer questions if we have that time, Gabby, or if you need to wrap up. But thank you for thinking about this.
Yeah, of course. Thank you, Laura, for such a wonderful presentation. Very informative. We do have a question in the chat box from Dave Haddock. It says, have you encountered a connection between MCI associated with long COVID and progression to dementia?
I don't think there's literature that supports that it would become a progressive condition at this point. I do think there's some evidence of individuals with long COVID who have some of that more, as I understand it, it's much more of a subcortical profile in terms of attention processing speed, seeming to get first. But I have not seen, and Dave, if you have it, please share any indication that that becomes a progressive dementia from long COVID. So if you've seen it, I'd love to see that data too.
Well, like you said, there hasn't been much time to develop that long-term studies. I just think it's something to be aware of. Does it also cause confusion in the diagnosis?
Mm-hmm.
If your patient has long COVID or maybe has long COVID and hasn't been diagnosed, because a lot of what you observed is seen in patients with long COVID.
Absolutely. And I think everything I've seen, and it's all, you're right, it's all kind of preliminary stuff. They've done several presentations on this at the National Academy of Neuropsychology recently, and all of the data that I've seen so far is looking at it much more like it would present similar to like the profile of like a vascular cerebrovascular related dementia at the MCI level initially. I just haven't seen it crossing over into the major neurocognitive disorders secondary to COVID. That hasn't, unless a patient had a stroke,
Yeah.
as a
How do you-
result of COVID.
How do you consider brain fog in this range of symptoms you've been describing? Brain fog is it different, unique, or
I think of brain fog much more as, in that kind of frontal lobe, slowed processing, difficulty kind of coming up with our words, and just thinking more slowly. It shows up for a lot of patients. People use that term. I've also heard that term used with different patients experiencing side effects from medications. It's not just COVID where we hear that term. Patients, with chronic pain, I've heard that term used there as well. So, I mean, that's not a separate diagnosis per se at this point.
Well, thank you.
Yeah. Certainly something to take seriously, listen to, hear how it's impacting functioning. I wouldn't say you could assess that with a MoCA or a mini mental. We'd need to take that further on to neuropsychology because it's just much more of a fine-tuned assessment. A little tougher, but even working in primary care, I think we could certainly work on some adaptive strategies and thinking about pacing of activities and thinking about what times of day people are better than others and giving them some more concrete strategies to help with that as well. I think there's another question.
Yeah, I can read it. This is
Okay.
from Nellie. How do you approach patients who might be in early stages of a dementia, but it is unclear how much mood is impacting and there is substance use with cannabis in a state that has recently legalized?
Yeah, it's so tough. I mean, that's hard. And I think we're going to see it a lot more. So a lot of times if I'm seeing cognitive issues and we have potential depression and substance abuse, I am not going to make a neurocognitive disorder diagnosis. It's too messy. Instead, and I think even neuropsychologists with a robust testing battery. So if you have all kinds of impairments in all these scales, but you're clinically severely depressed and smoking a ton of weed, it's too messy for me to determine what is the etiology of the impairment on my tests. So instead, what I'm going to say is I'm going to describe what I'm seeing in the impairments. We've got slowed processing speed. We've got some problems with attention. Your memory isn't as good. Now, why? neuropsychologists, we craft these lovely paragraphs at the end and we say, these are the descriptions of the problems, and I'm going to opine that it is likely related to this, this, and this, and a neurocognitive disorder at this time cannot be ruled out due to secondary factors. So we're going to treat your depression, we're going to get you off the weed, and after you've cleared out, come back and see me again. I think it's just important for us to be honest about what we know and what we don't know. And those things impact cognitive functioning. So we have to name them. And if the patient is motivated to improve their cognitive abilities, hopefully we will see some improvement in those areas. Hope that helps. It's messy.
We have one more. Thanks for this awesome presentation from Matt. I work predominantly with older adults, and we screen all patients annually with a mini-cog when they are older than 65. One thing we are running into, medical providers in primary care feel very uncomfortable delivering these diagnoses, often pass the buck to neurology to give the hard news. Any tips for how BHCs and PCPs can band together to deliver this diagnosis?
Yeah, Matt, yay on doing the mini cog annually. I'd love to get my people to do that. They just are like, don't give me one more thing. So I think you've advanced in your practice and I'm proud of you. I think sometimes PCPs give diagnoses when they shouldn't, because frankly, there's a lot of factors that need to be considered, and giving an Alzheimer's diagnosis when it could be a medication effect or something like that is very damaging to the person, to their family. So I'm okay with PCPs deferring to specialty on some of these things. I think we as BHCs can help our primary care providers by saying, all right, your mini cog is positive. Why don't you further clarify? So I personally don't view it as passing the buck as much as deferring to the experts in neurology and neuropsychology to do a more robust evaluation than is typically available in primary care. Now, if it's blatant and they just refuse to talk about it, then I think I would probably have the conversation with the PCP about trying to understand what do you look for as a primary care provider to feel confident in that diagnosis, or what is it that's getting in the way for you of talking to your patient about this concern. I think at minimum, hopefully your assessment with the patient in primary care should alert the primary care provider that for whatever reason, brain fog due to COVID, Alzheimer's as well. So you can help guide even if they don't make that hard and fast diagnosis, but I'm actually comfortable maybe more so with the PCPs deferring to some experts on some of these things, because I've seen some really bad diagnoses where everybody's Alzheimer's and then we actually miss things that's really going on with the patient.
All right. Thank you everyone for joining us. Just a quick reminder, our next meeting is going to be June 5th. That's a Wednesday, same time, 12 o'clock Central Time. So we hope to see you guys there.